Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hi, everyone. I'm Dave Tweed at Colorado State University, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute. Today, we're joined by Dr. Nicole Buote. And this is a very special webinar because she's actually on vacation with her family skiing in Vermont. So she's doing this webinar in her hotel room. So we really thank her for participating. She received her DVM from Tufts University, then internships at Angel Animal Medical Center in Boston and Dallas Veterinary Surgery Center, and then completed a surgical residency at the Animal Medical Center in New York. Then she worked in private practice in Southern California before joining Cornell University as an associate professor of soft tissue surgery. Her research focuses on mainly minimally invasive surgery and interventional radiology techniques. She's a diplomate of the American College of Veterinary Surgeons and founder of the Association of Women Veterinary Surgeons. Dr. Buote will tell us about her experiences in performing laparoscopic assisted splenectomy. So without further delay, Nicole, I'll turn it over to you.
Thank you so much. I'm so glad to be here. Thank you very much to the Translational Medicine Institute for allowing me to speak, and to Carl Stortz, obviously, for helping with this presentation. And I'm going to talk tonight about laparoscopic splenectomy. It's a procedure that I love performing. I love talking about it. Dr. Tweed already kind of gave you a little bit of my background, but as you can see, I've kind of been all over the place. I've been on the East Coast for a lot of my training and on the West Coast for a lot of my post-training career, and now I'm back at on the East Coast at Cornell. Very happy to be there right now. So tonight we're going to talk about the spleen. We're going to go over the anatomy of the spleen, some indications for splenectomy, preoperative diagnostic, surgical options, postoperative care, and some challenges and complications that you can see with a laparoscopic assisted or laparoscopic splenectomy. So diving right in, we all know about the spleen. The anatomy is pretty straightforward. It's usually found in the left cranial quadrant of the abdomen. It's about 0.2% the body weight in dogs and cats, and that is greater relatively than in people. So it's something to keep in mind as we're going to talk about some human studies with laparoscopic splenectomy. The head of the spleen is attached to the stomach through the gastrosplenic ligament. The tail of the spleen is more mobile and wider than the head of the spleen. And as you can see, the blood supply comes from the celiac artery. And we all remember that this gives rise to the pancreatic artery as well, the splenic. And that's really important with regard to our surgical technique, making sure that we don't ligate or tie off any of the kind of blood supply to that left pancreas. The spleen can also be characterized as either sinusoidal or non-sinusoidal, and that's a difference between dogs and cats. And I always think that's a really good boards question if we have any residents who are watching. So the dog has a sinusoidal spleen, which means that there's a combination of direct arteriovenous endothelial connections as well as these areas where the red blood cells actually have to traverse a region of red pulp before entering a venous sinus, whereas in cats, there's just these direct connections. So just keep that in mind. Very easy anatomy question for boards. The function of the spleen really can be split up into four major functions, and filtering microorganisms is one major function along with antigenic particles that might be floating around in our blood. Synthesis of IgG and cytokines is another important function. And then maturation and storage of red blood cells and storage of platelets is an important function. And we all know that the spleen is also responsible for removing old or senescent red blood cells. So this hematopoiesis function is a major source of red blood cells in fetuses, and can actually very interestingly come back into play in an adult in kind of times of hypoxia. So you can have an adult spleen who goes back into that kind of hematopoietic function role depending on the function of the bone marrow or severe hypoxia, which I thought was really interesting. As a reservoir, we have about 10 to 20% of our red blood cell mass and 30% of our platelet mass that lives in our spleen at any time. It's broken up into 3 different compartments. So a rapid pool, intermediate pool, and a slow pool. And it's really interesting that when there is a splenic contraction, you're going to get, 98% of all of the blood goes into that rapid pool, and you're going to get a contraction down of a 25 to 50% of your spleen, which is really interesting. And the reason I wrote this as sort of a consideration, the weight of the spleen and the mass, is because if we're talking about laparoscopic splenectomy, we really have to kind of take into account how big these spleens are. And we're going to talk about some stuff in people, and they've done some studies on what they characterize as massive or giant spleens and still being a candidate for laparoscopic splenectomy, but they do them a little bit different. But keep in mind that the spleen can be engorged with certain drugs. We all know about acepromazine and barbiturates, but butorphanol, diazepam, and metdetomidine and ketamine can also increase the size of your spleen. And the reason for that is not exactly well characterized, but they think it might have to do with relaxation of the smooth muscle and the capsule of the spleen. Getting back to a little bit of function, remember, immunologic function is really important. And we know that in dogs and cats, the spleen is sort of that first organ for filtering through a lot of these antigens that are going through our spleen. And that's why it's so important with disease processes like IMHA and ITP, because there are those IgG covered red blood cells or platelets. But microorganisms are really important too. So with diseases like Babesia, your spleen is going to be really important. Indications for splenectomy, we can really kind of break these up into a generalized splenomegaly reason versus a focal. And so what are generalized splenomegaly causes? You've got basically 4 different categories. So inflammation, which would be splenitis, and that's really characterized by cell type. So is it bacterial, viral? What kind of cell infiltrate is really there? It's most commonly seen with either chronic infections or a bacteremia. Your spleen will get enlarged with those types of processes. And then you've got your immune reactions. So you have this proliferation of normal cellular components, and that is what you're seeing with IMHA or ITP. There have been some really interesting systematic reviews in people on the immune reaction and how that creates a splenic enlargement. Then you have congestion, such as with right-sided congestive heart failure, portal hypertension, any kind of vascular outflow obstruction, or relaxant of the splenic capsule, like I said before, with different drugs can cause that. Or you have infiltration. So that would be something like a neoplastic infiltrate with lymphoma or mast cell tumor, or even amyloidosis. This is a picture of a infiltrative spleen that I took out. This was an IMHA or IMHA spleen, so I guess infiltrated with red blood cells that were being taken out. This article by Horgan et al. In JVEC 2009 was talking about splenectomies in dogs with IMHA. This was normal splenectomy, but I just put it in because we're going to be talking about different causes for a lap splenectomy, and you can do lap splenectomy for IMHA too. The median time from starting immunosuppressive medication in this paper to splenectomy was only 4 days, which is pretty quick. Most internists I know definitely try medical management a little bit longer before tapping me on the shoulder to help. but in this paper it was 4 days. They did see a significant increase in PCV 3 days post-splenectomy and a significant decrease in blood transfusions. They had 9 of their 10 dogs survive 30 days post-op. Wasn't really a very long follow-up in this paper, but 4 out of the 9 dogs were not on any medications post splenectomy, and they had, like I said, it was a few months sort of follow-up. So not the longest, but definitely had some pretty promising results with that paper. Other indications for lap splenectomy include a localized or focal lesion, and those can be obviously broken up into benign lesions such as nodular hyperplasia, which is one of our most common, hemangioma, which is sort of this well-differentiated endothelial cell mass that we can also see. Hamartomas, which are rare, they have the same type of cells as nodular hyperplasia, but they just don't have the normal architecture. So that's really kind of splitting hairs, but it's a pathology, pathology difference. And then you can also have pseudotumors as well. This is a picture of a lap splenectomy that I did for a nodular hyperplasia. And you can see that nodule right there on the sort of dorsal aspect of the spleen near the hilus. And then we all know that another focal lesion would be primary neoplasia. And so examples are hemangiosarcoma, any other type of sarcoma, lymphosarcoma and mast cell tumor can also look like a focal lesion. They don't always have to be infiltrative. So, you know, these metastatic lesions can also show up as well. That's just a picture of a mast cell tumor lesion that I took out. And the one before that was a hemangio. So that right there is the hemangiosarc coming off the head of a spleen. Other rare causes in animals especially, and in people as well, would be things like hematoma after blunt trauma, foreign body, abscessation, and segmental infarction, which is what that picture is right there. There have been some really interesting studies in people where they've used laparoscopic splenectomy for trauma, for blunt trauma. So these 2 papers that are listed there looked at blunt trauma and really found that they were able to do laparoscopic splenectomies very easily with stable blunt trauma. They matched, both of these studies looked at open versus laparoscopic spleens, and they matched for age and injury score. Laparoscopic splenectomy was usually chosen after medical management failed, or they failed an embolization period, or different type of procedure with embolization, and none of the laparoscopic procedures had any kind of worsened outcome with regard to mortality rate or hospitalization rate. They weren't better either, but they weren't worse. But they did have a much lower blood transfusion requirement than the open procedure. So that was actually something that was kind of nice in both papers. Big reason that people kind of worry about laparoscopic splenectomy is, when do we do them, you know? And so are you gonna do them with a dog like the dog on the left side where they have a hemoperitoneum? Probably not, right? But a dog on the right that does not have a hemoperitoneum, that looks pretty good. You know, you really want your clinical presentation to be appropriate. We don't want to take an unstable dog to a procedure that might take longer and that might have other sort of problems with anesthesia with regard to insufflation and tidal volume on their lungs. So most of the dogs that I do have splenic masses found incidentally. So they find them on imaging for other reasons. They find them on oncologic staging for other cancers. And obviously there's the immune diseases that we've talked about already. So the IMHA and ITP have also been reasons why I've done laparoscopic splenectomies. So most of the time clinical signs are either absent or they're associated with their primary disease, such as IMHA or ITP. So what are the preoperative diagnostics that I run? You know, pretty much for any surgery, depending on age of the patient, we're going to want our minimum database of blood work. So a CBC chemistry, coagulation testing, might be important. A DIC panel or a tag might be important, looking for D-dimers. And that's all based on what you're treating. If you're treating an older dog, you're going to probably want to get a thoracic MET check done just to make sure before taking them to surgery that you understand what might be going on in the lungs, because that's going to affect anesthesia. If it is a dog that we're really worried about a hemangio, an echo to check the right auricle is not a bad idea as well. So there's a lot of different kind of perioperative diagnostics that you would run depending on the disease that you think you're treating. Another important consideration would be whether or not your animal is anemic. So if you're doing a dog that has IMHA or ITP, most of the time they're going to have a lower hematocrit. The last ITP splenectomy I did, the hematocrit was in the 20s and the platelet count was in the 20,000. And so we definitely had typed and cross-matched that dogs. We had platelet transfusions ready to go, and whole blood also ready to go. And so it's just a consideration depending on what type of patient you have in front of you. Preoperative imaging runs the gamut from radiographs, which are pretty non-specific, to ultrasound up to CT and MRI. So radiographs are great, as a staging kind of a, survey tool, right? Because you can see masses in the spleen fairly comfortably, seeing that the intestines are kind of pushed back caudally, the stomach might be pushed cranially. That kind of gives you an overall view that there's something in the cranial abdomen, but it's not very specific. Whereas ultrasound is great at allowing us to see masses and nodules in the spleen and the liver. It can tell whether there's a torsion or not due to blood flow, and also due to the, kind of look of the parenchyma. And then you can also use contrast enhanced ultrasound, although I don't have any experience with that. The radiologists that I've worked with in the past haven't really used that for splenic or liver masses, but that's definitely been heavily reported. And then obviously Doppler is really nice on ultrasound to help give you an idea of, blood flow in some of these masses. So what we tend to use the most at our facility at Cornell is CT with contrast, and there have been multiple papers on it. This is just out of a paper looking at mast cell tumor staging. So, it's a big deal. We know that mast cells can definitely go to the spleen and to the liver. And, in this paper, there wasn't really a consistent pattern in related to the liver, whether or not they could diagnose a liver nodule that was a mast cell tumor met on a CT, but there were sort of a trend in these hypoattenuating nodules in the spleen being more commonly diagnosed as a mast cell tumor. So something to keep in mind. But what we really look at are these, here are some great examples of CT splenic masses. This paper was actually looking at whether or not you could try and diagnose a hemangiosarc or a malignant tumor versus a non-malignant tumor based off of the Hounsfield units or the density of the CT. And, really kind of nice paper. The image to the left all the way is a hematoma. The center image is a nodular hyperplasia nodule in the spleen, and the lesion all the way to the right is hemangiosarcoma. And so with this paper, they found that a threshold of less than 55 Hounsfield units was pretty accurate for diagnosing hemangiosarcoma. I think that we use that less at Cornell, the actual number, as much as we use, a lot of kind of other aspects of the mass, how cavitated it is, the blood supply to the capsule. But CTs are really, really helpful for us in kind of allowing us to see not only the spleen, but the extent of the disease, whether or not we're seeing liver nodules or mental nodules as well. It's really important to kind of help set up the, the owner too for what this procedure may entail. Fine needle aspirate can always also be done prior to any kind of surgery. This is a slide of hemangiosarcoma cells from a splenic aspirate. Cytology alone, the numbers are all over the place. There have been some studies that show really high accuracy rate, and then others, more of them tend to be around this 50 to 60% with cytology alone. And obviously there is a chance of bleeding and a chance of spreading neoplastic cells when you're aspirating these cavitated nodules or masses. So you do want to warn the owners of that. Fine needle aspirate can be very helpful for other organs, though, if you're doing a staging test, such as liver and lymph nodes. So if you have the time, if it's not an emergency, it's always nice to get a good, clear view of what you may be encountering in surgery. And so then talking about the surgical options, obviously we have traditional open splenectomy, and the indications for those would be larger tumors, hemoperitoneum, any kind of active hemorrhage, and an unstable patient. I don't think anyone would be, trying to say that rolling in a laparoscopic splenectomy for those cases would be a great idea. There are, however, some cases that are better for laparoscopic splenectomy, I think, in my opinion, and the opinion of probably some other surgeons. And those would be, cases in which there's a small to medium sort of focal nodular mass. You can still, I would say, do it for generalized splenomegaly. We'll talk about that a little bit later. And I think that you could also make the argument that if animals have a coagulopathy, it might be nicer to have smaller incisions and less trauma if it's possible to do it laparoscopically. Also, diffuse metastatic disease, if this is a really palliative kind of procedure, it might be nice to, once again, create as little pain for the patient as possible if they're only going to have a couple months left. Splenic size is the biggest kind of factor when deciding whether or not to do a lap splenectomy on the veterinary side as well as on the human side. And so I wrote down some of these considerations that you are going to want when deciding between these two procedures. So really consider the instrumentation you're going to be using. So are you going to be using a wound retractor, or are you going to be using something like a morcellator, which is fairly rarely used in veterinary medicine? On the small animal side, they use it more in the large animal side. But that would be something that would allow you to potentially get a larger volume of spleen out through smaller holes. Whereas the wound retractor does come in a couple different sizes, but there is a limit to what you're going to be able to, pull out of that wound retractor. You also want to consider the disease process. So are you going in after something that is malignant, like hemangiosarcoma? You really want to be following your oncologic principles. You do everything you can to avoid any kind of rupture of the mass. Or is this a benign procedure? Do you even know? Do you know if it's nodular hyperplasia versus hemangio? Most times we don't. Or is it IMHA? That isn't, it's not benign to the patient, but it's not a cancer. So, considering the disease process is going to be also really important. And then consider whether it's focal versus diffuse disease, because that too is going to determine how you manipulate this spleen intra-op. Human guidelines, there have been some newer papers saying that they can get a maximum spleen length of greater than 31 centimeters out, but the usual guidelines are about less than 25 centimeters of maximum spleen length, less than 1,000 mils of estimated splenic volume. And then some of the papers do talk about this length to width ratio instead. They definitely pay attention to the splenic size with regard to drugs and the different diseases, and then splenic mass size and type. So whether it's, smaller than 6 centimeters, whether it's cavitated, those are things to keep in mind. So this is a mass that I took out laparoscopically or lap assisted through a wound retractor, but there were definitely some moments of adrenal squeeze when I was taking this mass out, because it was about 6 centimeters and very cavitated. So very easy to rupture if I wasn't very gentle with it. So kind of keep that in mind. Having said that, this mass was about 8 centimeters in diameter, and I got this out through a wound retractor as well. This mass had a much kind of thicker capsule to it. So while I was still cavitated, I was able, you can see the Sills board there, the little insufflation part of the Sills board in that one. I was able to manipulate this a little bit better and kind of gently squeeze it out of the wound retractor, even though it was a little bit bigger. And so, you're all watching this, so I don't really have to talk to you about the reasons why MIS is better for our patients if possible, but here's my blatant plug for minimally invasive surgery for these cases. So patient selection considerations, again, we're going to be thinking about comorbidities like obesity that might make things a little bit more harder for manipulation intra-op. You're going to think about cardiac and pulmonary disease because that might make insufflation a little bit trickier for those patients. And then you're going to think about, endocrine disease like diabetes and Cushing's, and whether or not that's going to have any effect on the healing, the wound healing. But to be honest, I'd rather do an MIS procedure for a dog with diabetes than a wide open splenectomy with 3 times the incision length. Portal hypertension. This is actually interesting because in people, they will treat some types of portal hypertension with a splenectomy. And so this paper looked at different treatments with regard, it was a systematic review, but it looked at different treatments with regard to portal hypertension, and found that people did quite well with laparoscopic treatment of their splenectomy when they had portal hypertension. It was really interesting. A lot of them were able to kind of come off of some of their medications that they had been on, and they didn't have an increased risk of bleeding when they had it laparoscopically, and they got out of the hospital a little bit better as well, which was really nice. Ascites and coagulopathy. Those are always sort of relative contraindications to laparoscopy, but with our suctioning devices nowadays, we can really still get really good views of all of our intra-abdominal structures. And coagulopathy, once again, I think that might be a better reason to do MIS than not. Outcome in people of laparoscopic splenectomy versus open splenectomy, that's been looked at obviously a lot. This Casaccia paper looked at open versus lap in massive and giant spleens, and they categorized massive as greater than 20 centimeters and giant as greater than 25 centimeters. And what was interesting is their version of open was actually what we would consider lap assisted. So they went in with a scope originally, did some of the hilar resection and ligation, and then they did an enlargement of the subcostal incision to remove the spleen. So, pretty similar to what we consider to be lap assisted spleen is what their open was. But they did find that the laparoscopic, where they would sort of morcellate the spleen and remove it through smaller incisions, while it took longer, they did have reduced blood loss and they did have shorter hospitalization time. So that was kind of nice. The Shin paper also found the same thing about longer operative times, but in this paper, they didn't see the same advantage with regard to blood loss. And this paper did show a few conversions to an open approach in their laparoscopic group. There's been a lot of work on laparoscopy and laparoscopic splenectomy in children, which is a little sad that kids sometimes need their spleens taken out, but the number one reason tends to be these autoimmune diseases or these hematologic diseases. And so the top paper was looking at outcome and cost of splenectomy, laparoscopic splenectomy for ITP in children, and they were comparing it with medication or medical management. And they found some really promising results. About 86% of the kids were asymptomatic with platelet counts greater than 50,000 at a median of 15 months postoperatively, and the cost was significantly less than medical management. And they followed these kids out for a year. over a year. The Utria paper was looking at elective splenectomy, open versus laparoscopic. And the open had a 3 times higher risk of perioperative transfusion. And the laparoscopic also had a shorter hospitalization time in that paper. And so that, 2 days versus 4 days, if you're a mom or dad with your kid in the hospital, I think, is a pretty huge benefit. So I kind of blew through some of that. I don't know if there are any questions, Dr. Tweet, that we want to take care of right now or keep on going.
Yeah, and maybe some of these you'll comment a little bit later, but
Yeah.
Do you ever do this in cats, or is there an animal size that would limit your ability to do a laparoscopic assisted?
That is a great question. And there has been, we're going to talk about cats a little bit later, but yes, you can do it in cats. There's been a paper on cats published. I think really the only minimum size has to do with your equipment. And so if you're going to do cats, you probably want to invest in some 3mm cannulas. I won't lie to you. I've been doing some work on cats recently, and even the 3mm, I'm finding the length is a little troublesome trying to get stuff in there to have the same working length. So it can be a little bit more challenging, but if you're doing the lap assisted technique, which we'll talk about, your ability to do that in a cat, I think, is quite easy. So I think you could absolutely do this in a cat. If you had a cat with a splenic mass, or you're worried about mast cell tumor, although that would be rare, lymphoma, something like that, you could absolutely do it in a cat.
Yeah. We also, there's a question, can you comment on outcomes or complications in vet patients, or are you going to do that as well?
Yeah, I will be doing that. So we're going to get right into sort of the procedure, and then we're going to get into all of the veterinary stuff in just a few minutes.
Okay. Another question was, why don't we use morcellators in small animals?
I think that's a great question. I don't have an answer for that, other than I think we're just not as, familiar with that equipment, but I think that people are starting to look into that. I will tell you, I might be able to play a video a little bit later of what it entails to use a morcellator in people. But for example, they use it a lot for people with fibroids in women. You have to place the structure into a bag. Then you have to, well, you don't have to, but you usually place another cannula within the bag to blow the bag up, and to have your camera go into that bag as well as a morcellator. So you're having 2 trocars in this bag with the structure. So thinking of how big a spleen is, in a dog, and how big that bag would have to be, and then how big you would have to have 2 ports to be within it. It's challenging. It's not impossible, but I think it would be very difficult, keeping in mind that human spleens are not as big as dog spleens, relatively speaking. And so they're much easier to place within a bag. But I think morselization, we saw there was a recent paper coming out of Washington about morselizing adipose tissue. And as I said, I know they use it a lot in large animals. So I think it's an area that we need to look into. There's just some very important techniques to it, so that you're not spreading those cells all throughout your abdomen when you're cutting them up. So.
Okay. Good. We have a couple more questions, but they're more clinical related, so maybe we'll hold those till.
Yeah, I'm getting right into that.
Okay.
Awesome.
Why don't you go ahead then?
Awesome. Okay, well, so here we go. So patient prep for a lap splenectomy is basically a routine clip of the abdomen. You want to try and express the urinary bladder beforehand so that it's not kind of in your way. And then, as with all surgeries, you're going to be giving some perioperative antibiotics. We use cefazolin most commonly, unless it's an IMHA or ITP dog. And then, consider having your anesthesia team do either a tap block or getting some Nocita ready for closure to just help with, making that pain even less than it already is going to be. And then instrumentation, I talked about this a little bit ahead of time, but these are some of the commonly used, tools of the trade, so to speak. I use the Sills port and the wound retractor and a Cobra liver lobe retractor most of the times, as well as a ligature. But you can use blunt probes and fan retractors and Babcock forceps, all sorts of different things to be able to kind of lift up this very heavy spleen. Positioning a table setup. I just put a picture down there of how people are usually positioned, because I think it's always kind of interesting. But for me, I usually do them in dorsal recumbency, and I put them on a tilt table so that I can tilt them to the right if I need to get the spleen to kind of come towards me a little bit. You always have to kind of keep in mind your access to the head of the spleen and the short gastrix and that splenogastric ligament. And you can consider putting them sort of in reverse Trendelenburg as well if you needed a little bit of getting some of those organs off the spleen. There are basically two different kind of published port placements. Either the multi-port, which is on the left, or the Sills port, which is on the right. I do the Sills port technique and then place a wound retractor in that incision. But the multi-port, usually you're going to be putting your camera in that central port and your sort of dissector in your left and your ligature or vessel sealing device in your right. The thing to keep in mind with the Sills port is that you want to understand that your trajectory is going to be a little bit more difficult. And so this is a picture of my setup. You can see the instruments are going to have to be a little bit more parallel than obviously the multi-port. And so that can be a little bit challenging if you're just getting started with that kind of trajectory. With the multi-port, you're going to be, same thing. You're going to be wanting to sort of put your blunt probe or your fan retractor in. You're going to consider having one of those ports be a 10 to 12 millimeter port for a retrieval bag if you think you can put your spleen into that bag. Or you can always connect two of those port incisions, put a wound retractor in. So it can also be converted to a wound retractor technique. And there's just a picture of sort of like a blunt probe. That's a picture of something you probably don't want to do too much. You want to be very careful with your blunt probe that you're not necessarily poking the spleen like I'm showing you in that picture. I'd love to blame that on a resident, but that was me. You really want to use if you're going to use your blunt probe, sort of the side of it and sweep a little bit, because you can pop through a spleen pretty easily. And that's kind of a nice view of, the hilus, right? You want to kind of have that spleen flipped over so you can start going right across the hilus with your vessel sealing device. This was a really nice paper looking at just a little case series on 10 dogs with the multi-port technique. And, they commented that the positioning varied a lot due to concurrent procedures that they were performing with this paper. And so they did end up converting in one dog due to increased abdominal fat and sort of these omental adhesions that were getting in their way. But otherwise, they had no postoperative complications. And only 3 out of their 10 dogs were actually diagnosed with neoplasia. And they all, they did really well. Then you have this Mayhew paper that looked at 22 dogs with the Sills port. And so that is that other technique we were talking about. They had a median weight of 9 kgs, pretty small. They had a splenic mass or nodule in 14 of the dogs, splenomegaly in 4, and immune disease in the rest of them. And their largest splenic mass diameter was about 5 centimeters. In 6 of the dogs, they had mild capsular bleeding, and they had to convert in 6 of those 6 dogs as well. 5 just were converted to lap assisted with the Alexis port, and 1 actually was converted to an open approach. And they found that a heavier body weight actually significantly was associated with conversion, which is actually interesting, because I would have from clinical experience thought it would have been the opposite. This paper is a little bit older, from 2012, but it actually compared Sills dogs and multi-port dogs for splenectomies. And they found that they had a significantly shorter surgical time in the multi-port dogs. I'm sorry, in the Sills dog, and a shorter incision length. But other than that, they found no differences with post-op complications, and they didn't have to convert in either of them. So really kind of showing that both of these are very good techniques, and they're both, both very reasonable. And then you have sort of this lap assisted splenectomy technique. And this is very similar to in people where they do something called a hand assisted laparoscopic splenectomy. And basically the port prevents, in people, they have ports that prevent a loss of pneumoperitoneum. So it's not like the Alexis, which is the wound retractor right there. It has a little flange over top of it that they can put their hand in and still have pneumoperitoneum, which is kind of cool. But they use that for larger spleens. This is pretty significantly similar, though, to this technique with this picture here, where you're going to kind of remove the spleen and start dissecting or ligating the hilus outside of the body, as opposed to doing all of it sort of within the body. If you're going to do that technique with the Alexis or with a wound retractor, you want to consider that where you place this wound retractor, because you're going to have to ligate the head of the spleen and the gastric ligament outside of the body, which means you're going to have to be able to pull it kind of all the way out. So I always tell my residents, if you're going to do it this way, you have to position the wound retractor cranial to the umbilicus so that you have more flexibility to move that spleen out of the body in order to ligate those vessels. This is just sort of some pictures of one of the lap-assisted splenectomies we've done recently. And just, this is with a Sills port in, so you can still get some nice liver biopsies. That's the Cobra liver retractor, which I really like because it allows you to have sort of a longer length. And then you get this beautiful view of the sort of tail of the spleen to start your dissection. And here's just some video of sort of kind of surveying the spleen. And, I'm always amazed, even when you try to avoid drugs, that's a little bit of entry dancing by my resident, how big these spleens can be. And so this is a blunt probe, and it's just trying to kind of get around the edges of this spleen. And look at how big this is, going all the way back. It's a pretty large spleen to be taking out laparoscopically, but it's really, and then you can see how you can really lift up, look at the hilus, and then you can, continue your explore. And I won't make you guys sit through all of that, but you can do a really nice explore, look at those liver lesions, and get some good biopsies, as well as taking the spleen out. This is a video a little bit later on of just sort of what ligating with the vessel sealing device can look like. It can be tricky depending on the size of the patient with how much working space you have and lifting up this really heavy spleen, as you can see. So we were kind of figuring out different ways to put that Cobra retractor to really hold it up. There are also things like laparoscopic paddles that you can put in there that are really helpful. But as we're, dissecting down a little bit later on, we kind of hit a little bit of a bleeder. But we can have, it's a really nice view of the splenic artery and vein that we're coming up across right now, which I think it can be a little bit tricky depending on how much fat your hilus is sort of encased in. And once again, how much visualization you have by lifting that spleen up. Depending on where your mass is too, it can be a little bit problematic, but looking pretty good. And so then, once again, if you decide that you're going to do a lap assisted, you're going to maybe dissect and ligate as many of the vessels along the hilus as you can. And then when you get to a point where, either you think it's safer to take the spleen out, you're going to convert your Sills incision into an Alexis incision, just like this. And so take the Sills out, you enlarge the incision a little bit, you put a wound retractor in, they come in different sizes, and then you gently exteriorize the spleen and continue your dissection and ligation with the vessel sealing device outside of the body of the animal. And there you go. There's a nice spleen. And that's just a picture from a human lap splenectomy, kind of what they have, what their incisions look like when they do these, what we would consider lap assisted. So looking at this study by Wright et al. And Javma, they looked at 18 dogs, and they had this lap-assisted wound retractor placed after a laparoscopic explore with this progressive exteriorization of the spleen. Their splenic masses range in size from 1.6 up to 11 centimeters by 1.5 to 14 centimeters. So they were getting, bigger spleens out with this lap-assisted technique. They did not have any conversion to a true open surgery. Their median incision size was about 7.5 centimeters. And they did a bunch of other concurrent procedures, and all the animals did very well post-operatively, which was great. Closure, this is what it usually looks like with a lap-assisted splenectomy. Pretty small, it's at least a third, only 1/3 the size of a normal Explorer, with, I think, still very good results. Post-op care in my hands will be an incisional block with no CETA if they didn't get a tap block ahead of time by anesthesia. Sometimes 1 to 2 doses of an opioid post-op. Usually, I would say 1, but sometimes 2, depends on the dog. Sometimes an NSAID, depending on the disease process and any kind of comorbidities. Once again, if it's immune disease dog, they're going to be on pred, so they're not going to get an NSAID. And then we switch them to oral pregabalin and use our perioperative antibiotics just like we would for any surgery. If they've had any kind of arrhythmia preoperatively or intraoperatively, they'll be on an EKG for 24 hours. And then they're discharged the next day because they're usually quite comfortable and doing well. Complications that you can see with laparoscopic splenectomy can be broken up into either intraoperative or postoperative. So intraoperative, there's always a risk with any laparoscopy that there could be some insufflation related complication. And so, you always want to be really chatty with your anesthesia department, make sure that they're not noting any issues with tidal volume or any SpO2 reading difficulties during the procedure. Because you don't want to, end the procedure and then find out after the fact. Hemorrhage is obviously a risk with any splenectomy. That can happen during the initial trocar placement. It's quite common. A little bit higher risk with that if you're going to use a varus needle technique. I do a modified Hassan. So I, make a small mini laparotomy to place my trocars in. That has a little bit less of a chance of damaging the spleen, but not 100%. Manipulation with probes and retractors, like I said, you can easily poke into the spleen or poke into a cavitated mass with those blunt probes. And the side of a fan retractor is also quite sharp. So you want to be very careful about digging that into a spleen while lifting it up. And then, of course, you can have hemorrhage if you have inadequate sealing with your bipolar sealing device. I would say usually these types of hemorrhage are not hemodynamically significant and they can be handled fairly rapidly laparoscopically. But every once in a while, if you actually rupture a mass, you're going to have to probably convert to get that spleen out a little bit quicker. Splenic rupture, again, it's a risk if you are manipulating the spleen or the mass a little bit too rough. I've definitely done it, trying to remove a spleen out of an incision. When they are coming through a wound retractor, luckily, you feel like things are pretty well kind of cleared off from the rest of the peritoneum, but you definitely, if you rupture a splenic mass, you can seed tumor. I mean, you have to admit that that's a possibility, although very rare. Overall complication rates in human medicine, 15%. with lap versus 26% with open. In veterinary medicine, lap, there have been much smaller papers, so the complications would be something like conversion, and that's only been reported in 1 out of 10 dogs, so about 0 to 10% risk, versus open splenectomy has a little bit higher risk of 7 to 11%, but many more papers on open. So it's a little hard to say exactly. And we really don't have any comparison studies to date looking at open versus laparoscopic in the same cohort of dogs. And so we really don't know what the comparison is in veterinary medicine like they do in people. In people, they have this complication called OSPI, which is overwhelming infections that they see post splenectomy. And this is a lifelong risk of an overwhelming infection. And so that's something that I think we don't see, because sadly, many of our animals that get splenectomy have cancer or terminal disease, and they don't maybe live long enough to see this. But it's something that I'm interested in looking at, because obviously, with more and more diagnostics and more people being proactive, I feel that I know I'm taking out a lot more spleens with benign disease in them. And so does that mean that we are setting up some of our patients for this possible complication? I think maybe we are, because we're being so proactive about taking the spleen out. And even though I've been accused of not liking or respecting the spleen, because I take them out so much, I think, having done the research for this is something that we're going to have to maybe start looking at as a complication. This was a picture from a human study, and the reason I show it is I wanted to show sort of the size difference, that you can see with this is an adult person's spleen. And in this paper, they're looking at only doing partial splenectomy because of this risk of lifelong infection when you take the spleen out. And so they were dissecting through the pedicle, and the spleen sort of more to the right has already been dissected of its blood supply. So it's got this bluish purplish tinge, and they're going to go right through the rest of that spleen and save a little bit of spleen for this person. Another complication of splenectomy with open or lap is portal thrombus. That has been reported in about 3% in humans, as well as in dogs, actually. Mortality rate in people is only about 10%. Our mortality rate is much higher on the veterinary side. And so they consider in people doing thromboprophylaxis if they're really worried about it. And they will actually recheck Doppler ultrasounds 1 week after laparoscopic splenectomy to check for any thrombosis. And they see about a 20% incidence that is aclinical, asymptomatic within a week after splenectomy, and they'll put them on thromboembolics if they see that. Other thrombotic complications that you can see if you have a portal thrombus is deep vein thrombosis or a pulmonary embolus. So something really important to think about. Incisional infection or inflammation that can obviously show up. There's been a few papers looking at how a laparoscopic spleen versus an open splenectomy has less infection rate. There's also been other papers, just MIS in general has a smaller infection rate. Pancreatitis has been reported in humans post-splenectomy. We haven't reported that on the vet side. And obviously you can see thrombocytosis and leukocytosis as well. That's usually a good thing if you're doing, doing the splenectomy for ITP, but maybe not a good thing if you're not. So some other things to just think about would be doing partial splenectomies. And that's not necessarily a new thing, right? We can do those already open or with the lap. But they're, once again, looking at that a lot more now that we have bipolar sealing devices. You could do it with endoscopic stapling devices as well. Potentially, it would be something that we could offer if we knew what we were taking out, with regard to some of these masses. Might be a nice thing if you're taking something out and it turns out to just be nodular hyperplasia, you've basically taken out a big immune function of that patient. And then in people too, they're looking into robotic splenectomies, which have obviously a longer surgery time, but a significantly less risk of postoperative bleeding. So I know that's not going to be coming to the vet side anytime too soon, but you never know. Some really sort of interesting things out there. And that's all I have. I'd be happy to take some more questions.
Okay, that was really great. There are a couple of questions. One is, do you have any tips to make it easier to get the spleen in a retrieval bag?
I think it depends on port placement. That would be my number one thing with regard to the retrieval bag. Because if you're going to be doing it through, I think a lot of the times in my experience, it's easiest to do it through a fourth port. If you're going to do the multi-port and put that port off a little bit, like right pericostal, so that you can kind of scoop the spleen, into it. If you're going to do a Sills approach, and this would be something for sort of like trying to fragment the spleen to get it in. It's really hard from a Sills approach to go through the Sills in my hands. Like I said, I always have to put an additional port in order to be able to try and get the trajectory, triangulate that bag to get the spleen in. So I guess that's what I would say is, if you're going to try and put it into a bag, I would wait until you've sort of done your dissection, and then I would figure out where you think it's best based on the size of your spleen to put that extra port. That's what I've done. I've just waited to put my 10 millimeter port when I know where I want it to go, so that it's easier.
Okay. Do you know if there are any studies looking at the rate of tumor seeding laparoscopic versus open?
So not specific to splenectomy for sure. There were some studies many years ago looking at tumor seeding with CO2 insufflation, and they were we didn't have a lot of evidence that tumor seeding occurred, except for in some thoracic cases with mesothelioma. We definitely can see that. And so I think the risk of tumor seeding is quite low. If you think of, unfortunately, going into a hemoabdomen of a ruptured hemangiosarcoma, you're suctioning up a lot of cancer cells and blood that's just been bathed in that abdomen. And we don't usually see a lot of those dogs, granted, many of them pass away within 6 months, but tumor seeding doesn't seem to be sort of what gets them. And so, with regard to splenic tumors specifically, no, we don't have any evidence of that. And the evidence back in for stuff like TCC, there just hasn't been a lot of evidence that shows that it's a high risk. I think it's always a risk, but it's not something that would keep me up at night if one of these masses ruptured on the way out when I was taking them out.
Another question is, do you ever go in laparoscopically just to stage the patient? I mean, to biopsy, to look for metastasis, and then decide where you're going to go from there?
Absolutely. I do that all the time. And I try to explain to, my residents and the students that I think that this is something that I wish we did more of as a field, because I think it adds so much. Even if you wanted to do a lap-assisted splenectomy, where you want to take the whole spleen out basically and ligate everything from the outside, you could make a 6 centimeter incision and do that without a scope tower, right? You could just do that. You don't need the tower. But what the tower allows you to do, what the scope allows you to do, is put that camera in and look at everything, right? Get those liver biopsies, get a view of the diaphragm, get a view of the serosal surfaces of everything in the peritoneum, and take biopsies as needed. And you would miss all of that if you just made a small incision and pulled the spleen out. And so I think it's completely reasonable to stick a port in, take a look, get some biopsies, and make a much more minimal incision, or convert completely at that point, depending on what you see. But the amount of magnification and the amount of detail that you're going to get with the scope is just really, to me, super valuable in those cases.
Okay. Well, that is all the questions we had. So we really appreciate your willingness to contribute to our endoscopy talks, and thank the audience for participating. In 2 weeks, we'll learn about laparoscopic adrenalectomy presented by Mead Singh from the Ontario Veterinary College, University of Guelph. That session will take place Wednesday, April 21st at 8 p.m. New York time. So we look forward to seeing you then. And in the meantime, wishing you all the best of health. Thank you very much. Hi, I'm David Tweed here at Colorado State University's Translational Medicine Institute, inviting you to attend our hands-on Introduction to Flexible GI Endoscopy. This course is intended for those that have never touched an endoscope and are considering GI endoscopy as a new skill, or for those that have an endoscope collecting dust in the closet after becoming frustrated performing endoscopy. If that's you, then this course fits your needs. We have a great group of instructors with years and years of experience. In the lab, the groups are small with lots of student-instructor interaction, and you will endoscope at least 4 or more different animals. You will learn how to set up and handle the endoscope. You will learn the normal, important endoscopic anatomy, as well as what is abnormal, tips on getting through the pylorus, how to find the ileum, and how to get the best biopsy samples possible. You will also practice removing multiple different esophageal and gastric foreign bodies, learning the tricks of our instructors. So, if you want to learn flexible GI endoscopy or simply improve your skills, then this is the course. To get more information or to register for this course or other endoscopy courses I teach, simply go to csuvetce.com. If you have specific course content related questions, email us and I will personally answer your questions.